Hi, I'm Rochelle Andriotti. I am a professor of clinical radiology and associate professor of obstetric and gynecology at Vanderbilt University Medical Center. And I'm going to be speaking today on an approach to acute and chronic pelvic pain. I'd like to emphasize the importance of sonography as the imaging modality of choice for evaluation of suspected acute and chronic gynecologic etiologies of pelvic pain. Then I'd like to illustrate the use of ultrasound when a non-gynecological etiology of pain is suspected, and as an effective substitute to CT for pregnant patients as well as patients in the reproductive age group in view of the lack of ionizing radiation. I'd also like to illustrate the use of MRI as a problem-solving tool when the ultrasound exam isn't adequate or in place of CT in pregnant patients with suspected appendicitis. So what is the concern? Well, the frequency. Pelvic pain may account for up to 40% of gynecologic visits. It's the most common reason for hysterectomies. And it's a common reason for laparoscopy, the most common reason in the UK and the second most in the United States. So where does imaging fit in? The diagnostic considerations are based on whether it's a GYN or OB cause or a gastrointestinal and genitourinary cause, or other causes that may be vascular or musculoskeletal. According to the ACR appropriateness criteria on acute pelvic pain in the reproductive age group, the selection of imaging is determined by clinically suspected differential diagnoses following a careful evaluation. Sonography is the modality of choice for a suspected gynecologic or obstetrical abnormality, and CT more useful for a GI or GU abnormality, although MRI is definitely favored over CT in the pregnant patient. But ultrasound may be a reasonable alternative. So why is sonography the modality of choice? It's non-invasive, radiation-free, cost-effective. It gives high-resolution anatomic detail of the uterus and adnexa. And we try to use both sonographic techniques whenever possible, since they're complementary, with transvaginal ultrasound whenever possible, when there's no contraindications due to its better resolution, and transabdominal sonography providing more information when structures are beyond the field of view of the probe. So when we use sonography with abdominal compression, we can displace bowel, bring structures closer to the transducer, identify focal areas of tenderness, and also use what we call the sliding organ sign to separate structures. Here on the cine clip, you can see where the transducer is pushing between two structures, an ectopic pregnancy and a cyst within the ovary, demonstrating that they slide by each other consistent with separate structures. So what is the role of Doppler? Spectral and color or power Doppler imaging can be used to characterize vascularity in the ovaries, fallopian tubes, and uterus and narrow our differential considerations. When we look at this article that was published by Harris in 2000 in Radiology, he addressed actually pelvic pain and a normal pelvic sonogram. He looked at 86 non-gravid patients without symptoms of infection, systemic illness, or bleeding. The majority of these patients had improvement or resolution of pain, 77% of them. And he also found that further imaging was unlikely to yield positive results. Of 13 studies that were done in these patients, only one yielded a diagnosis. So a normal ultrasound can be a powerful finding. So how about pelvic pain and CT? Computed tomography is used more frequently when a GI or GU abnormality is likely, but gynecologic disease is being detected with increasing frequency because it's quick due to advances in technology leading to faster acquisition times, as well as 24-hour accessibility. So what about acute pelvic pain and MRI? MRI is favored over CT for assessing the pregnant patient due to the lack of ionizing radiation, but its use may be hampered because of its lack of widespread availability, especially in the acute setting. So MRI is also a problem-solving tool following ultrasound for specific indications, if further characterization of disorder is required, or if the patient's pain fails to resolve and becomes more chronic in nature. So now some definitions. First, acute pain, which is intense pain characterized by sudden onset. Chronic pain is a non-cyclic pain that lasts 6 months or longer, which is severe enough to cause functional disability or the need for medical care. And then we have cyclic pain, which is pain associated with the menstrual cycle, usually referred to as dysmenorrhea. So in our approach to imaging the patient with pelvic pain, we will look at acute pelvic pain, chronic pelvic pain, and dysmenorrhea. First, acute pelvic pain. With a patient presenting with acute pelvic pain, there are often other signs and symptoms, which include fever, nausea and vomiting, leukocytosis, abnormal vaginal bleeding. And also, at this time, we need to determine the pregnancy status. Should ectopic pregnancy be under consideration? And is there concern for fetal exposure to ionizing radiation, making ultrasound or MRI the initial imaging modality of choice? So we check a serum beta-HCG level. A negative level essentially excludes the diagnosis of an intrauterine or extrauterine pregnancy. And if we have a positive beta-HCG level, then we need to look at obstetrical causes of acute pelvic pain in the first trimester. And this would boil down to either a failed intrauterine pregnancy or an ectopic pregnancy. But in today's talk, we are going to mainly be discussing the gynecologic causes of acute pelvic pain, looking at problems mainly arising from the adnexa. So the most common causes are functional ovarian cysts, pelvic inflammatory disease, and ovarian torsion. First, non-neoplastic cysts, which can be either simple or hemorrhagic. A follicular cyst is the most common, an abnormal follicular enlargement due to anovulation, commonly associated with hemorrhage with rapid resorption. The corpus luteum, which is a normal structure that often enlarges with hemorrhage. Corpus lutein cysts, which are corpus lutea that enlarge, usually during pregnancy, associated with resolution by 14 weeks gestation. And then the least common type, the thecalutean cysts, associated with trophoblastic disease, multiple gestations, and usually are large and numerous and may persist for weeks after withdrawal of the stimulus. So what causes the pain of an ovarian cyst? Its large size, usually greater than about 25 to 30 millimeters, hemorrhage, rupture or leakage. The characteristic appearance of a hemorrhagic cyst with hemolysis and retraction of clot, a reticular network of stranding is demonstrated. Or we may see a fluid-fluid level between fluid components and congealed red blood cells that may give a concave margin. These are the most specific findings, and when seen, may be considered diagnostic of hemorrhagic cysts. Acute hemorrhage can also be hyperechoic, suggestive of a solid mass. A diffuse pattern of low-level echoes could also be seen, more commonly associated with an endometrioma. Then we may have internal echoes and septations, and leakage of hemorrhagic fluid associated with peritoneal irritation. Often we make the diagnosis by looking at the evolution of the cyst, which usually resolves. Here we have a thick-walled cyst with a homogeneous echo pattern and septations associated with echogenic fluid. 10 days later, we see involution, confirming the presence of a hemorrhagic cyst. There's still a little bit of fluid leakage around it. But Usually there is no change in the appearance of this cyst unless the patient has either undergone a normal menstrual cycle or the cyst has ruptured. So we usually wait about 1 to 2 menstrual cycles or 6 to 8 weeks to assess for resolution. And then how does Doppler help us? We see peripheral color Doppler signal, no central vascularity, and low impedance arterial flow. In this patient, we see a characteristic hemorrhagic cyst with a reticular pattern with flow within its periphery, both arterial and venous. These findings actually may be more helpful with a solid appearing cyst, since the lack of internal flow can help us make the diagnosis of a cyst rather than a solid mass. Let's move on to pelvic inflammatory disease. This consists of inflammation of the endometrium, fallopian tubes, pelvic peritoneum, and adjacent structures causing fever, leukocytosis, and cervical motion tenderness. It's usually caused by an ascending infection by Neisseria gonorrhea, chlamydia, or superinfecting organisms from the vagina, now usually referred to as bacterial vaginosis. It's manifested by Tubo-ovarian complexes, peritonitis, and abscess formation. It's usually bilateral, but may be unilateral in patients with IUDs, although nowadays it's less commonly seen with IUDs due to the use of the Mirena and the progesterone effect, which blocks ascension of bacteria by increasing cervical mucus. A Netter drawing showing a characteristic tubo-ovarian complex, and an intraoperative photo also showing the uterus, broad ligaments, and the dilated fallopian tube with purulent material on its surface. So let's look at the clinical diagnosis of PID. No simple diagnostic test exists, and the accuracy with which signs and symptoms predict the presence of PID has been evaluated using a laparoscopic gold standard. And this has been looked at in a retrospective review by Sims and colleagues in 2003. The data set included women who attended the Department of Obstetrics and Gynecology, Lund University Hospital, Sweden, with suspected PID, collected between 1960 and 1969. All patients included in the study had an initial diagnosis based on the clinical presentation. A total of 623 patients were included in the analysis. 494 patients were laparoscopically confirmed as having PID, and 129 were not. They found that 3 variables significantly influenced the prediction of PID, which were the elevated sed rate, fever, and adnexal tenderness, but together they correctly classified only 65% of women with laparoscopically diagnosed PID. So this was a real problem. So how can transvaginal sonography help us? Actually, transvaginal sonography can only detect complications of PID since early changes are often subtle, although color Doppler may actually enhance our capabilities. The problem is that there is difficulty visualizing the tubal wall without surrounding fluid. But with surrounding fluid, common findings include wall thickness of greater than 5 millimeters, incomplete septa, thickening of endosalpingeal folds, which is considered the cogwheel sign. There are also nonspecific findings of fluid in the endometrial cavity and/or cul-de-sac, and ovarian enlargement, often referred to as the polycystic ovary appearance with numerous small cysts displayed. So in this patient with a normal appearing fallopian tube and ovary, when we use color Doppler, we actually see a lot of color Doppler flow within the tube, which helps us to make the diagnosis of salpingitis. Another patient with a fluid distended fallopian tube with echogenic fluid. Of course, this could be either blood or purulent material, but using color Doppler, we see that there is flow within the wall, which would be consistent with inflammation. A third example of salpingitis with a markedly distended fallopian tube and flow within the wall. This patient could actually be confused with a patient with a cyst in the ovary, but seeing an incomplete septum within the mass suggests that this is a fallopian tube rather than a septated cyst within the ovary. So now we move on to a more severe form of PID, which is the tubo-ovarian complex. This is progression of disease with exudation of pus from the distal fallopian tube so that an inflammatory mass, including the tube and adjacent ovary, is formed, but the ovary is still visualized as a separate structure. So we see here the ovary and adjacent fallopian tube in these two transvaginal images, but the ovary can still be seen separate from the distended fallopian tube that contains echogenic fluid. So then we move on to the tubo-ovarian abscess, the most severe form of PID, where the imaging definition consists of a complete breakdown of architecture so that separate structures are no longer demonstrated. Here we have a mass in two views with a cystic area that has what looks like incomplete septa, so this is suggestive of the fallopian tube, but we cannot separate this from the ovary. And another example of a tubo-ovarian abscess, also both with conglomerate masses of tube and ovary, where the tube is suggested by the thickened endosalpingeal folds, which we refer to as the cogwheel sign. There's also increased flow by color Doppler surrounding this mass, consistent with the inflammation surrounding the abscess. So where does CT fit in the diagnosis of PID? Given the vague and nonspecific symptoms, CT is often the first imaging study performed. What we see are thick-walled, fluid-filled fallopian tubes, but it is often difficult to differentiate among a pyosalpinx, TOC, and TOA by CT. And also, this exposes patients to ionizing radiation, which is problematic among young women. So we see two slices of a CT exam within this patient where there are thickened fallopian tubes that contain fluid. And does MRI have a role in the diagnosis of PID? According to UDA, in an article published in 2002, MRI may be more accurate than transvaginal sonography if Doppler is not used. However, cost, lack of access, and limited data preclude its widespread use. And here we have an example of MR and CT imaging of a tubo-ovarian abscess, where we see a peripherally enhancing fluid collection. Usually, sexually transmitted disease-initiated infection is not evaluated with MR. So there aren't very many examples around. But this was given to me by Dr. Susanna Lee at Mass General Hospital. And what we see is a CT enhancing appendix and mass, and adjacent to it, a tubo-ovarian abscess. The anatomic detail is not well seen on CT, so an MRI was performed. What we see on T2 and T1 fat-sat images with MRI are fluid and inflammation within the mass, which is the hyperintense area centrally and peripherally on the MRI study. And on the T1 fat-sat image, we see wall enhancement around the mass, which is the hyperintense enhanced area surrounding the mass on this transverse T1 image. Now moving to ovarian torsion. The diagnosis of torsion is strongly considered with abrupt onset of severe unilateral pain. It's most commonly seen with associated nausea and vomiting. The pain may be constant or intermittent, depending on whether it might be partial or intermittent torsion. However, symptoms may be variable. And the diagnosis of adnexal torsion has remained a clinical and imaging enigma due to the vague clinical presentation, with abdominal pain being the only consistent symptom. So the common denominator of ovarian torsion is the enlarged, abnormal appearing ovary, usually due to benign ovarian tumors or cysts in up to 80%, which may act as a fulcrum to potentiate torsion due to increased ovarian volume or weight. Also, ovarian hormone induction can lead to hyperstimulation with enlargement of follicles, leading to a fulcrum for torsion as well. Another cause could be a hemorrhagic corpus luteum of pregnancy, or hypermobile adnexa, a congenital problem usually seen only in the pediatric population. So a problem often encountered in evaluation of torsion is a result of the vascularity to the ovary, which can be either from the uterine artery and vein or the ovarian artery vein, giving us a dual blood supply and meeting at the pampiniform plexus that feeds the ovary. When we look at the pathophysiology of torsion, first, lymphatic and venous drainage is compromised. Then there's congestion and edema, as we see here in this diagram, and then loss of arterial perfusion. So we finally have an organ that looks like this, enlarged, black, and ugly. So complete and unalleviated torsion can progress rapidly to occlusion of the arterial circulation. The organ may quickly become very dark black in color due to hemorrhage, necrosis, and gangrenous changes. So early intervention is key. It decreases the incidence of complications and improves ovarian salvage rates. And the use of pelvic sonography has enhanced our ability to determine when intervention is advisable. Nevertheless, gynecologists often delay surgery because of misleading ultrasound findings, only to find a non-viable tissue upon exploration. So once again, the common denominator of the vast majority of cases of torsion is an enlarged ovary or ovarian complex. So we see here an enlarged edematous ovary, and here the ovarian complex that consists of ovary with hemorrhagic cyst. Within the edematous ovary, we may see irregular internal texture suggesting hemorrhage and edema, peripherally placed follicles, and within this ovary, homogeneous low-level echoes centrally consistent with edema. So where does Doppler fit in as far as torsion? We would assume that color and spectral Doppler would prove to be an accurate tool for the evaluation of ovarian torsion, but in actuality, Doppler findings vary depending on degree of torsion and its chronicity. So the lack of arterial and venous signal should enable confident diagnosis. But there are false positive diagnoses, and this is usually due to technical problems such as depth of penetration greater than beam capabilities or improper Doppler or grayscale settings. Here's an example of a patient with a paratubal cyst, an enlarged edematous ovary, and power Doppler demonstrating no evidence of flow in the ovary, and we're seeing normal flow in the iliac artery and vein, so we know that we are penetrating deep enough so this diagnosis is likely accurate. On the other side of the coin, ovarian color Doppler signal has been frequently reported in cases of surgically proven torsion. In a retrospective series of 39 patients with pathologically proven ovarian torsion performed at Vanderbilt Medical Center, 21 of these, or 54%, had documented ovarian arterial Doppler signal only. But what's more important is that 33% of these patients had documented ovarian, venous, and arterial signal. So we will see arterial and venous flow in a large percentage of patients with surgically proven torsion. Here's an example showing the enlarged edematous ovary with surgical proof of torsion, and arterial and venous flow demonstrated within this mass. A more specific vascular sign of torsion is the twisted pedicle sign, often referred to as the whirlpool sign. But this sign is not very sensitive because the ovarian pedicle must be targeted in order to be demonstrated, and this is not routinely imaged on our routine exams. But we are seeing flow within a twisted pedicle on this image and also on the surgical path specimen, which is diagnostic of ovarian torsion. So how do we diagnose ovarian torsion with ultrasound? The most consistent finding is the enlarged edematous ovary or ovarian complex. Doppler findings may vary, likely depending on degree and chronicity. The lack of Doppler flow enables fairly confident diagnosis, but arterial and venous Doppler signal has been routinely reported in up to a third of surgically proven cases of ovarian torsion. And is there a role for CT or MRI? Sonography is the initial exam of choice, but computed tomography is being used more frequently, so it's important to be familiar with findings of torsion by CT. And most of this is due to trying to rule out appendicitis in the abdomen. So the CT features include, well, here we have a large cyst, which turned out to be a para-ovarian cyst. We see thickening of the fallopian tube around the ovary, considered the target sign. We may see deviation of the uterus toward the site of torsion, and infiltration of adjacent fat, as we see here. By CT, we may also see the twisted pedicle sign. Here we have an ovarian mass with thickened edematous ovarian cortex and lack of contrast enhancement, and the beak configuration of the engorged vessels are seen, which suggests the twisted pedicle. And is there a role for MRI? This has not been established. Ra and colleagues have shown similar diagnostic findings with both MR and CT in a study published in 2002. An example of MRI of ovarian torsion, we can see here a normal appearing ovary with follicles on this T2 weighted coronal image, and an enlarged ovary adjacent to it, showing a heterogeneous hyperintense pattern due to edema and hemorrhage centrally, and peripherally placed follicles. So now we move to non-gynecologic causes of acute pelvic pain. These include appendicitis, diverticulitis, intestinal obstruction, inflammatory bowel disease, and ureteral calculi. All of these where imaging plays a role. Common gastrointestinal and genitourinary causes where ultrasound plays a role include appendicitis, ureteral calculi, and inflammatory bowel disease, although I place a question next to this since this is not routinely performed in the United States. So appendicitis is the most common GI cause of pelvic pain in women. It is a diffuse or periumbilical pain that migrates to the right lower quadrant. CT with contrast is the imaging modality of choice to confirm the diagnosis in non-pregnant females with a very high sensitivity and specificity. But ultrasound may be an effective substitute with a sensitivity varying from about 67 to 100%, and specificity of 83 to 96%. So the sensitivity is variable because of its user dependence. So ultrasound with graded compression is the initial imaging test in the pregnant female, but is often inconclusive due to the large uterus. But MRI would be the next imaging modality due to the lack of ionizing radiation. A blind-ended, thick-walled, tubular, non-compressible aperistaltic structure is seen, as we see here. At least a 3 millimeter single wall thickness is demonstrated, and there's an intact echogenic submucosal layer in uncomplicated appendicitis, as we see here. There also may be surrounding echogenic fat. We may see increased vascularity within the wall of the inflamed appendix. With complicated appendicitis, there may be a different appearance with marked thickening of the mucosal layer, as we see here, that's strikingly echogenic periappendiceal fat, and fluid surrounding this structure in the form of an abscess. CT features of appendicitis include an enlarged appendix greater than 6 millimeters, as seen here on this coronal CT image, with thickened enhancing of the wall and pericecal fat stranding. MR features of appendicitis are similar to CT, but we use a negative oral contrast agent that demonstrates low signal in the bowel on this coronal T2 weighted image. And also in the normal appendix that we see right here. In this coronal view of the pelvis using a T2 weighted, in T2 weighted image, the enlarged edematous appendix is demonstrated. That is very hyperintense without any gastromark contrast within it. So we have a fluid-filled, inflamed appendix, and we can make this diagnosis. Moving on to the urinary tract, we can use ultrasound to look for ureteral calculi. First, with ureteral calculi, the patient presents with costovertebral angle pain that radiates to the groin rather than true pelvic pain. It is best detected by non-contrast CT with a high sensitivity and specificity, but an alternative for evaluation of the distal ureter is transabdominal or transvaginal sonography, especially in pregnant females. So on these transabdominal images, we see hydronephrosis, and then within the distal ureter, we may often demonstrate an obstructing calculus and echogenic focus with associated shadowing. Another patient with hydronephrosis and echogenic foci seen within the distal ureter using transvaginal sonography, which demonstrate posterior acoustic shadowing, as well as a twinkle artifact, which is a new Doppler finding that has been associated, although not very specific, for calculi. And then we come to inflammatory bowel disease, which is a systemic inflammatory problem that requires close monitoring to prevent disability. Surveillance of the disease activity is necessary to determine when medical management is needed. CT in the past has been the imaging modality of choice, but there is a lot of evidence now that questions the safety of giving frequent ionizing radiation. MRI is effective and radiation-free, but it is expensive and often inaccessible. Transvaginal sonography has been found to be highly effective for detecting inflammatory activity. So here on this longitudinal scan from a report in European radiology, we see thickening of the muscularis within this loop of bowel with a large ulcer pointed out with the black arrow, causing focal interruption of the submucosa. We can also use ultrasound with contrast enhancement to look at activity of inflammation in inflammatory bowel disease. On this cross-sectional image of a loop of thickened ileum in a patient with Crohn's disease from a report in radiology by Wilson and Burns, we see enhancement of the wall of the bowel, which you can see the arrows are pointing to. We also see enhancement adjacent to the bowel within the fat, and this enhancement has been described in the literature as the comb sign, which also is suggestive of active disease. Then we move on to a vascular etiology of pelvic pain, ovarian vein thrombosis. This is most commonly seen in postpartum patients, although ultrasound is usually the initial imaging modality. CT and MRI are known to perform better than ultrasound in this diagnosis. And what we will see with CT or MRI is enhancement of the periphery of the vessel with a central non-enhancing thrombus. However, I'd like to just show you a case where the CT was actually not as diagnostic as the ultrasound, since we are not completely within the venous phase when the slices were taken. So we see the enhancing left ovarian vein, which is normal, but it's difficult to pick out the abnormal right ovarian vein since there is no evidence of enhancement, even peripherally. And the ovarian vein in the pelvis also is not enhancing, so it's hard to differentiate it from the adjacent bowel. However, by ultrasound, we actually see a distended ovarian vein that contains thrombus with only peripheral power Doppler flow within the vein. So in our approach to pelvic pain, when it comes to acute pain, first we need to decide whether we have an obstetrical or gynecologic cause of pain. And of course, then we will go to ultrasound as our modality of choice, or whether we suspect a non-gynecologic etiology of pain. And then we need to determine whether we have a positive or negative beta HCG level, because if we have a positive beta HCG level, then ultrasound or MRI are the modalities of choice. With a negative beta HCG level, CT does have a higher sensitivity when it comes to the etiologies of non-gynecologic pelvic pain, but ultrasound may still be a reasonable alternative. Now I'd like to emphasize the importance of sonography, the imaging modality of choice for the evaluation of suspected chronic gynecologic etiologies of pelvic pain, with gynecologic etiologies being the most common cause of chronic pelvic pain. And also how we can use MRI as a problem-solving tool for specific indications, if further characterization of a disorder is required, or if the patient's pain fails to resolve or is more chronic in nature. So common etiologies with imaging findings in chronic pain would be endometriosis, adenomyosis, pelvic varices, malpositioned IUDs, and inflammatory bowel disease. So endometriosis is the most common benign gynecologic disorder. It's a result of functional endometrial tissue outside of the uterine cavity and musculature. And what we see are cysts, or endometriomas, plaques, implants, or nodules. So here on this Netter drawing, we can see how endometriosis can affect just about anywhere within the pelvis, including the ovary, uterine ligaments, pouch of Douglas, pelvic peritoneum, and even abdominal scars. Symptoms of endometriosis include dysmenorrhea, dyspareunia, and abnormal bleeding. And the severity of pain may not correlate with the extent of disease. First, let's talk about the role of ultrasound in diagnosis. Historically, the most recognized and readily diagnosed appearance of disease has been the endometrioma. However, confirmation must be obtained with time. Also, presently, there are multiple reports of visualized implants using targeted sonography. So we may be able to use sonography for more than just looking for an endometrioma. So what do we see, though, with a classic endometrioma? We'll see single or multiple thick-walled cystic masses with diffuse low-level homogeneous echoes, as we see here. And also, we may see hyperechoic foci along the wall of these cysts. So more recently, ultrasound has found to be able to be used to evaluate implants found in dependent areas of the pelvis, including the cul-de-sac, the uterosacral ligaments, the bladder, bowel wall, and rectovaginal septum. So what we like to do is target areas where the patient complains of focal pain. And by targeting these areas, we will find these implants. What we find are usually solid and hypoechoic areas. In the bowel wall, the implant takes the form of a nodular or fusiform swelling. It may also be a rounded solid structure that we may see within the cervix. An image from radiographics very nicely depicting the fusiform area behind the uterus that we see here, and along the anterior wall of the rectum, which is consistent with a nodule of endometriosis. At our institution, we've used this technique and have found, as we see here, a nodule in a patient status post a supracervical hysterectomy at the junction of the cervix and the vagina with some peripheral color Doppler flow, which proved to be a cervical implant of endometriosis. Here is another example of an endometriotic implant in the posterior cul-de-sac. Here we have a sagittal view of the uterus, a transverse view, and this small hypoechoic nodule adjacent to the fundus within the cul-de-sac that proved to be an endometriotic implant. So what is the role of MRI as a problem-solving tool in the diagnosis of endometriosis? Well, with MRI, we can have immediate gratification. We don't have to wait to see if an endometrioma will resolve. MRI has high sensitivity and specificity in diagnosing deep and nodular endometriosis in addition to the cystic type as well. However, plaque-like lesions may go undetected until laparoscopy. So how can we use MRI to make the diagnosis of cystic endometriosis? We see T1 increased signal, and on the T2 weighted images, we may see a characteristic shading, but we may also see heterogeneous or homogeneous increased signal. So here on this transverse view of the pelvis, we see hyperintense signal within the mass. On the coronal T2 weighted view of the pelvis, we see the T2 weighted image with shading of the mass. In another case, courtesy of Dr. Lee at MGH, we have a transabdominal sonogram showing two cystic masses within the pelvis. And on T1 and T2 weighted MRI images, we can see that these cysts do different things with the different sequences. When we look carefully, we see that the structure on the right, on the T1 weighted image, is hypointense, and on the T2 weighted image is hyperintense, consistent with a hemorrhagic cyst. Whereas the two structures on the left side of the pelvis are hyperintense on a T1 weighted image, and on T2 weighted images, the larger structure shows some shading, but also some heterogeneity. The smaller structure shows a high intensity signal, again, on the T2 weighted images, but both are consistent with endometriomas. So what about MRI and nodular endometriosis? With nodular endometriosis, we may see a T1 intermediate signal, but we always will see foci of high intensity signal within the intermediate signal. And on T2 weighted images, we see variable signal characteristics. So on these two images, first a T1 fat sat in the transverse plane, we see a fusiform, highly hyperintense area that's associated with the anterior rectal wall. And on this sagittal T2 weighted image, it once again looks hyperintense. So this is consistent with the fusiform implant that we may see associated with the rectal wall. Another example showing a transverse MR T1 fat sat weighted image of the pelvis. Here we see uterus, and adjacent to the uterus, a small implant which shows intermediate signal, but areas of hyperintense foci within it, consistent with an implant. Now let's move on to another cause of chronic pelvic pain, the tender uterus, which may be related to adenomyosis or possibly pelvic congestion. So adenomyosis is a very common gynecological condition characterized by the presence of ectopic endometrial glands and hyperplastic stroma in the myometrium. It is estimated that it is present in up to 30% of females and 70% of path specimens status post-hysterectomy. It is commonly incorrectly labeled as fibroids, usually seen in the older reproductive age group. Ultrasound has a reported sensitivity of 80 to 87% and specificity of 94 to 98%. Symptoms usually include uterine tenderness, dysmenorrhea, and menorrhagia. And the sonographic signs include a globular configuration of the uterus, abnormal myometrial echotexture, heterogeneous myometrial echotexture, often with associated linear shadowing, poor definition of the endometrial myometrial junction, pseudo-widening of the endometrium, an elliptical myometrial abnormality but relative absence of a discrete mass, and color Doppler signal may be present or even increased within the area. First, a globular configuration of the uterus on this sagittal transvaginal image. On this cine clip, we can see hypoechoic areas corresponding to smooth muscle hypertrophy, as well as echogenic heterotopic endometrial tissue. We may see myometrial cysts corresponding to dilated glands or hemorrhagic foci. Ectopic glands may be seen, and they actually may be echogenic due to hemorrhage within the glands. The process may be focal, as we see here in the anterior myometrium, or diffuse throughout the uterus. We often see linear hypoechoic shadowing, as we see here. And this is associated with smooth muscle hypertrophy on the pathological examination. The endometrial myometrial junction may be very poorly defined. And we can see here on this image that the myometrium is very heterogeneous, and it's very difficult to pick out exactly where the endometrium is. It's most likely this very faint line. So that we may not be able to determine the thickness of the endometrium by transvaginal imaging, and we may measure the endometrium a lot wider than it really is. So the most accurate findings, according to a fairly recent report by Kep in 2007, are a globular enlarged uterus, subendometrial linear hypoechoic striations which is considered the most specific feature, and myometrial cysts. So let's talk about adenomyosis and fibroids, since these two are often confused. With adenomyosis, there is a relative absence of a discrete mass, but an elliptical myometrial abnormality or adenomyoma may be seen, but will not change the uterine or endometrial contour, as we can see here. Another case of an elliptical myometrial abnormality within a retroverted uterus, seen by transvaginal sonography. But once again, the uterine contour is unchanged. As opposed to leiomyomas, as we see here on this longitudinal and transverse view of the uterus, there is a change in the contour of the uterus with this small leiomyoma. So how can color Doppler help us? With leiomyomas, we see peripheral vascularity usually. But vascularity with adenomyosis may be present or even increased throughout the area in question. In fact, it may have what we call a stippled effect within the myometrium. And optimized for low flow may be the most valuable technique for differentiation of the two processes. So some pearls in the evaluation of fibroids and adenomyosis. There's a high reported sensitivity and specificity distinguishing between the two. The majority of patients with adenomyosis, however, also have fibroids, according to a report by Bromley in JUM in 2000. The relationship between heterogeneity of the uterus and severe disease is there only when fibroids are not present, according to a report by Holka in AJR in 2002. And according to a report by Bazat in 2002, 6 out of 16 false negative studies in this series were attributed to limited myometrial evaluation due to fibroids. So we can see on this cine clip some fibroids in the posterior myometrium, but it's very difficult to make out what's going on anteriorly, where we do see some evidence of striations that would represent adenomyosis as well. So adenomyosis may be easily overlooked when fibroids are present, even though they are often seen concurrently. So moving on to how MRI can help us as a problem-solving tool in the evaluation of adenomyosis. It's highly accurate with a sensitivity and specificity of 86 to 100% and an overall accuracy of 85 to 90%. But the accuracies of sonography and MRI are similar. Sonography is usually the first study obtained in the patient with pelvic symptoms, but MRI may give additional information in those cases which are indeterminate by transvaginal sonography. So the MR signs are best seen on T2 weighted images. We may see abnormal myometrial signal intensity, which are low signal intensity due to the hyperplastic smooth muscle, and areas of high signal intensity due to the heterotopic glands. So here we have on sagittal and transverse T2 weighted images the hypointense smooth muscle with some areas that show hyperintense foci, which are the hyperplastic glands. But we may also see thickening of the junctional zone. In this coronal view, we can see here endometrium, junctional zone, the area between the endometrium and the more normal myometrium, which is fairly hyperintense, that is very thickened. We may see linear striations of high signal intensity, but these striations are different than those seen on ultrasound in that these are associated with the endometrium, and this may also be associated with a pseudo-widening of the endometrium So we will see some fuzziness around the endometrium with these small linear striations projecting, and poor definition of the endometrial myometrial junction. So in this example, a transverse and sagittal T2-weighted images of the pelvis, we see linear striations associated with the endometrium here and here. And also, this is causing a pseudo-widening of the endometrium. The junctional zone is markedly thickened in this patient. And we see heterotopic hyperintense foci, which are the glands within the myometrium. So moving on then to the other cause of uterine tenderness or pelvic congestion syndrome. This is chronic pelvic pain that is associated with dilatation of pelvic veins and reduced venous return. It is a dull chronic pain exacerbated by prolonged standing and relieved by lying down and elevating the legs. Often, sonography is used in the initial assessment to rule out other pelvic etiologies with similar symptoms, but has also been shown to be of value in the diagnosis. So we may see the presence of these tortuous dilated vessels, the venous plexes in the adnexa, and with color Doppler, we may see that these dilated veins, the arcuate veins within the uterus, may be seen crossing the myometrium. Other sonographic signs include dilatation of ovarian veins from 6 to 10 millimeters in diameter with reverse caudal flow, polycystic-like changes of the ovary, or variable spectral Doppler waveforms in the veins during the Valsalva maneuver, as we can see represented here in this image from AJR, which shows a spectral Doppler of an ovarian vein, and with Valsalva at this arrow, we see reversal of flow. But venography remains the gold standard, and the diagnosis can be made with an ovarian vein diameter greater than 10 millimeters, demonstrating reflux. Other causes of chronic pelvic pain include, first, ovarian remnant syndrome, an uncommon condition occurring after unilateral or bilateral oophorectomy with or without a hysterectomy. So a fragment of ovarian tissue is left behind encased in adhesions, becoming functional and or cystic, causing the patient chronic pelvic pain. So we can see in these images the multiseptated ovarian mass in a patient status post-hysterectomy with a rim of ovarian tissue seen on both the sagittal and transverse views using transvaginal sonography. Okay, we often see intrauterine contraceptive devices in patients causing pelvic pain. These are easily visualized by transvaginal sonography due to their increased echogenicity and marked attenuation of the sound beam. An abnormal position may cause chronic pain. So by transvaginal sonography, we can confirm the position of the IUD in the uterus, and when abnormally located, may show that part of the IUD is embedded in the myometrium. 3D ultrasound using reconstructions in the coronal plane can be especially useful in improving our visualization of the entire IUD. So we have a 3D reconstructed image, a surface rendered image, showing a satisfactory IUD location with shaft in the main cavity and the two short arms within the uterine cornu. Another image, 3D reconstruction, showing an unsatisfactory IUD location fairly low in the cavity with one of the short arms embedded in the myometrium on the left side. And here's an example of how we can be misled by 2D ultrasound. The shaft of the IUD looks like it's in fairly good location within the endometrial cavity on this 2D sagittal image. But when we do the 3D reconstruction, we can see that it is obviously displaced, that is low in the cavity in an oblique position with the left short arm embedded within the myometrium. So in our approach to chronic pelvic pain, we have ultrasound as the modality of choice, and then we have MRI as our problem-solving tool. And finally, we have cyclic pain or dysmenorrhea. This is cyclic pain during menstruation. It may be divided into primary or secondary dysmenorrhea. Primary dysmenorrhea if there is no underlying pelvic pathology and no direct imaging findings, but imaging may be useful, especially ultrasound, to exclude other causes. This is usually seen in the younger menstruating age group, and the pain usually begins a few hours before or shortly after the onset of menses and may last 2 to 3 days. Secondary dysmenorrhea is due to an underlying pelvic pathology. And this may present with a more variable type of pelvic pain than the primary dysmenorrhea. And then as far as causes of secondary dysmenorrhea, the majority of them we've already covered, since they may also cause chronic pelvic pain that is non-cyclic. These would include endometriosis, adenomyosis, IUDs, and pelvic congestion syndrome. We also have some other less common causes of secondary dysmenorrhea that have some interesting presentations. First, the uterine anomaly, the uterus didelphys here with an obstructing vaginal septum as an example. We can see this drawing from radiographics showing the vertical septum attached to the wall of the vagina, which could definitely cause a significant obstruction from the outflow of menstruation of the right uterine horn. A patient with exactly this problem, demonstrating a hematocolpos by transabdominal imaging. This is a 13-year-old, so transvaginal imaging was not performed, and evaluation of the problem by transabdominal imaging is not extremely accurate, so an MRI of the pelvis was performed in this patient, which shows very nicely the normal appearing left vagina, left cervix, and the hematocolpos on the right. I also have some examples of dysmenorrhea due to adhesions. We have a patient here with a cornual hydrosalpinx post-endometrial ablation. With endometrial ablation, we have an adherent cavity within the majority of the uterus, but the cornual areas may not be ablated distally, and functioning endometrial tissue may still bleed, causing these cornual collections, especially if there is distal tubal obstruction. These collections will cause pain with menstruation. Another example of adhesions causing a hematocolpos, one patient following a LEAP procedure, and a loop electrosurgical excision procedure that uses a thin, low-voltage electrified wire loop to cut out abnormal dysplastic tissue in patients with cervical dysplasia. And of course, this type of procedure can result in cervical stenosis and distension of the patient's cervix and endometrial cavity as well with menstruation. So once again, our approach to pelvic cyclic pain, we have primary dysmenorrhea, and really no imaging findings would be found here, but ultrasound may be used to rule out other etiologies. And then we have secondary dysmenorrhea, which would be worked up similarly to chronic pelvic pain, since mostly it has very similar etiologies, with ultrasound being the modality of choice and MRI our problem-solving tool. So also, before concluding, just some points to ponder regarding radiation. which supports more emphasis on the use of ultrasound and even MRI when appropriate, rather than modalities such as CT that use ionizing radiation. First, a pelvic CT in a pregnant patient delivers up to 2.5 rads, increasing fetal radiation dose to approximately 10-fold above background. This dose is well below the estimated threshold risk for fetal malformations. However, linear extrapolation from cancer rates observed in atomic bomb survivors suggests that a pelvic CT could increase the risk for developing cancer by 0.3%, or about 1 in 300 in a fetus in utero, 1 in 400 in a 10-year-old girl, and 1 in 1,000 in a 30-year-old woman. So the use of ultrasound cannot be stressed enough. Sonography is the initial imaging modality of choice for evaluation of suspected gynecologic etiologies of pelvic pain. Sonography is also an effective substitute to CT for evaluation of non-gynecologic causes in patients in the reproductive age group, especially pregnant patients. And MRI should be used as a problem-solving tool when ultrasound is not adequate, or in place of CT in pregnant patients with suspected appendicitis. So here is just an overview of the entire approach to pelvic pain, where we have acute pelvic pain, which should be divided into GYN or OB cause versus suspected non-GYN cause, chronic pelvic pain, and cyclic pain. And thank you very much for your attention.